Hello, everybody, and welcome to Hughes Clues, Respiratory Failure with Mechanical Ventilation and Airway Management. Notice all of the topics that we're going to cover in this module. There's a lot. Mechanical ventilation is usually somewhat confusing for students. So I am going to go into quite a bit of detail on the explanation so that it will make more sense to you. There is really more questions on the test are going to be related to what is the nursing implication, but I don't think you'll understand the nursing implication unless you understand how it is that the mechanical ventilator works. So when we start out, we've got a 65-year-old person that's brought to the emergency department with worsening dyspnea. And the assessment findings show that the patient's in moderate distress, use of accessory muscles and wheezing. The respiratory rate is 30 breaths per minute. The heart rate is 120, blood pressure 170/90. And then I have the ABGs listed for you here. So what I recommend you do is to pause the recording and first try and interpret the ABG, and then I'm going to answer some questions about what clinical manifestations suggest respiratory failure. What does clinical manifestation means? Those are simply signs and symptoms. That's a fancy way of saying that. And then what treatment would you anticipate? When we look at the ABG, we're going to first interpret what we have or what we notice is going on. So we look first at the pH. If you did not listen to the Hughes Clues REST ABG analysis, then some of this may not make sense. But if you did, hopefully this is easy for you at this point. So we look at the pH. We see that the pH is down. The patient has uncompensated acidosis. Next, we look at the CO2, and we see that the CO2 is up. We see that the CO2 is up, the bicarbonate is normal. So we have, because the pH is down and the CO2 is up, when we look at Rome, respiratory opposite or metabolic equal as the cause of our abnormal ABG, we can see that the arrows are opposite, so therefore we have a respiratory cause, so we have an uncompensated respiratory acidosis. And then we look further and we check out the oxygenation status of the patient, and we see that the PO2 is 78 and the SAT is 89. So this patient does, by definition, have hypoxemia. We have uncompensated respiratory acidosis with hypoxemia. So what manifestations would suggest that a patient has respiratory failure? Well, this is where it's very important as you're looking at an exam question that you look at the descriptors for the patient. So when you look at this patient, you could very easily in the clinical setting see what looks like respiratory failure, but on an exam you have to go by the descriptor. And so the descriptors were that they were using accessory muscles, and they were wheezing, and they had a rapid respiratory rate, and they had signs and symptoms of SNS stimulation, which is sympathetic nervous system stimulation. In other words, when patients feel like they're going to die when they're not breathing, then they will have the SNS activation, and the heart rate will go up and the blood pressure may go up also. Now, if I had listed cyanosis, you would know that that's definitely a sign of respiratory failure, but as healthcare providers, we want to make sure that we interrupt or intervene long before the patient presents with cyanosis. But all of the above findings indicate that the patient is in respiratory distress. This is a very distressed patient with increased work of breathing, WOB, work of breathing. So respiratory failure is really defined when the respiratory system cannot do what it is tasked to do, which is ensure that the pH falls within a normal range and that the patient has oxygen and that the patient is able to blow off CO2. And because everything within this blood gas indicates that the respiratory system is doing neither of those three things, then this is what defines or describes respiratory failure. So respiratory failure is present when retained CO2 causes a respiratory acidosis and there is hypoxemia. So what treatment would you anticipate? Again, this is where you go back to the basics. Go back to Junior 1, go back to Junior 2. Sometimes Dr. Reed will throw in a question where it is just simply the answer is something simple, like Put the head of the bed up, give supplemental oxygen, try and help liquefy secretions by giving humidified oxygenation. And if some of you think, well, you know what, if this was a COPD patient, would we want to be cautious about giving oxygen? Well, yes, you would. You wouldn't just give them the highest amount possible. It would either be very, very specific oxygen delivery, and that's where the respiratory therapist will come in for this. But the rule of thumb is usually give the lowest amount for the least amount of time, and to ensure oxygenation of the patient. That's the whole thing with O2. I mean, if they're hypoxic or hypoxemia, you have to give them oxygen. You can't just say, well, you're a COPD patient. We're going to put you at risk if we do give you oxygen. Well, they're going to die if you don't. So you're going to have to intervene. The patient may get a breathing treatment. We would obviously elevate the head of the bed. If the scenario had read that the patient had just returned from surgery from an anesthetic, then you would turn cough and have them deep breathe. We may give them steroids if we feel like this is an inflammatory, infectious process. We want to ensure that the hemoglobin level is present, but because of these profound abnormality and that this patient is truly distressed, another option is to give CPAP. CPAP stands for continuous positive airway pressure. Now, this patient, we're going to say in our scenario, is placed on CPAP because we don't necessarily want to do the most invasive first. We want to try the least invasive. And you can see with CPAP that this is simply a specialized mask and machine that is used to help. So what is the purpose? Well, the machine exerts positive pressure, and it's continuous positive airway pressure throughout the respiratory cycle. And what this does is it helps the alveoli stay open. It keeps the alveoli from collapsing. So if you inhale, the alveoli will open, and then as you exhale, the alveoli can close, and we don't want the alveoli to close completely. We want the alveoli to stay somewhat open, and so we can help them by giving this positive airway pressure. Again, this goes back to it's a physics thing. And if you want, you talk to your respiratory therapy about all the physics of this. It is not necessary knowledge for this course. What you do need to know is if your patient is on CPAP, what are the things that you, the nurse, assess for? So the good thing about CPAP is that it is delivered non-invasively. It may prevent intubation. In other words, it can maybe get a patient through a crisis so that we don't have to do more invasive maneuvers for them. And it helps keep the alveoli open longer so that there is a longer time for gas exchange. The disadvantages is it does increase the work of breathing. These patients have to inhale in that mask, and a lot of patients are very claustrophobic. That's probably the wrong word, but they don't like things on their face. And so they also must exhale forcibly against the CPAP and inhale a little bit more. So therefore, it would be used cautiously if the patient was having a respiratory problem and had a history of coronary artery disease or was currently having a respiratory and a cardiac problem at the same time. And then once this mechanism or this maneuver is deployed, again by the respiratory therapist, then when should the next ABGs be drawn? Now, before I answer that question, I do want to say that you might have heard of CPAP, you might have heard of BiPAP, and inquiring minds, if you want to know some of the differences, then just email me. When should we draw an ABG? In other words, when should we assess, or how soon should we assess whether this machine, whether this non-invasive maneuver is helping improve the patient's conditions? And usually whenever there is a change in treatment for a patient, such as adding oxygen or putting them on CPAP, then you should wait about 20 to 30 minutes before you get an arterial blood gas. Notice if you had suctioned the patients or doing anything to change their respiratory settings or could change their oxygenation level, then you need to wait about 20 to 30 minutes before ABGs are drawn. And in that time frame, let's say in our scenario that the patient is now diaphoretic and they're more restless. They have repeat ABGs are drawn, and here's what the values are and the corresponding vital signs. So again, go ahead and pause the recording interpret the blood gas, and then consider what treatment do you think should be or would occur next, and why would that treatment be there. So when you see this blood gas, you notice, again, if you have it written down in front of you, you'll notice that the pH from our previous sample is actually lower. In other words, the non-invasive maneuver didn't help. And not only has the pH gone down, has worsened, but the CO2 has gone up, and the oxygen status has gone down. So what is the treatment for this patient? Well, this patient has to be intubated. The patient has to be intubated and placed on mechanical ventilation. Again, because of worsening CO2, worsening vital signs as evidenced by the increasing heart rate, respiratory rate, the decreased blood pressure, the diaphoresis. The restlessness is an indication that the lack of oxygenation or the elevation in the CO2 has caused altered mental status, or that the patient is getting this impending sense of doom. This patient is distressed. And if the healthcare provider doesn't intervene, then this patient can have either a respiratory and or a cardio pulmonary arrest. So this patient can decline very rapidly. And when I talk about intubation, this is what I'm talking about. This is the process of putting a tube in and down into the lungs and then breathing for the patient. So let's describe the process and the key nursing interventions that should be deployed during the intubation of a patient. Now, I'm going to note or call to your attention that I have a website, a YouTube video that I've referenced. And if you haven't ever seen an intubation or you're not familiar with the terms that I'm using, I strongly encourage you to watch this YouTube video. So pause the recording and go to this site. And here's why. Visualization of the process will help you. It'll help make sense of the things that I'm about to describe. Number two, online students, you guys won't even see a patient in critical care setting until after exam one. And there are about 4 questions on airway management of a patient on exam one. And students often miss them because it doesn't make sense to you unless you've seen it. So let's go back to the process of intubation. That's inserting this tube. Notice that the first thing you really want to do, because if you go back and look at your ABGs, you'll notice that the oxygenation status is very, very poor. And as you start maneuvering and manipulating this patient, you're going to stop pretty much all breathing. And so you really want to ensure oxygenation. So you want to grab the BVM, which is bag valve mask, otherwise known as an ambu bag, and you want to bag this patient. In other words, every time you have the patient's breathing stopped, hold your breath and see how long you can go before you take in a deep breath. Consider that as you're taking care of your patient, and push that physician out of the way if you feel like the patient needs to be bagged, as in you need to give breaths to the patient. So sometimes individuals will remove dentures because you don't want to break them. And then this patient will likely, if the patient is awake and combative, then they may be given sedatives and a paralytic agent. That's a respiratory muscle and all muscle paralytic agent. The healthcare provider will insert the endotracheal tube. Notice that the endotracheal tube, or you can't really notice because you don't see one without it, but this balloon on the endotracheal tube is inflated. So before the tube goes in, this balloon is deflated. So what you're going to do is the healthcare provider is going to, or CRNA is going to insert this tube. It is supposed to go into the lungs. This tube back behind the trachea is the esophagus. So the tube is going to go into the lungs. It is going to sit above the carina, which is where the two bronchial, right and left main stem bronchus, bifurcate or switch to go to the right and left lung. And once that tube is supposedly inserted in the proper place, you're going to put that ambu bag on this endotracheal tube and give in air. So give 2 puffs, and you're going to watch for the chest to rise and fall. The chest, both sides, should rise and fall. If you don't see a rise and fall in the chest, and breath sounds are not heard because you're going to auscultate at the same time, then you have to assume that this tube is not in the right place, that instead of going into the trachea, it went into the esophagus, which means your patient is not being ventilated, and if you don't ventilate your patient, they can arrest. So if breath sounds are not heard in the lungs, or breath sounds are heard in the epigastric area, the tube's in the wrong place, the tube should be completely removed. Then you push the physician aside, you bag the patient again to give more breaths, and then the healthcare provider will reattempt to intubate. Once bilateral breath sounds are heard, then this balloon will be inflated. And I want you to notice that ET tube, endotracheal tube, the balloon of the endotracheal tube will be inflated 20 millimeters of mercury plus or minus 5, which means it'll be between 5 and 25. This is an important number to remember. Notice, when I want you to remember something, I bold it and I underline it, and there's a reason for that. Now, we do check for the endotracheal tube measurement at the lips to ensure that the tube is in the right place. We will auscultate always, always, always. If there's any doubt about the placement of the tube, we'll auscultate first. And if we hear breath sounds, we will get confirmation. Notice confirmation with a chest x-ray. We do not check for initial confirmation with an x-ray because in most facilities it takes about 45 minutes, and if you have this tube in the esophagus and then you wait 45 minutes before confirming that this tube's in the wrong place, again, your patient's going to die. So chest x-ray confirmation should just be what it says. Confirmation means it should be confirming what you, the healthcare provider, already know, that the tube is in the trachea. What is the purpose of the balloon on the at the end of the endotracheal tube, and why is 20 millimeters of mercury underlined? Well, the balloon, the endotracheal balloon, allows the ventilator to push air into the patient's lung under positive pressure. Notice that if this balloon was deflated and then you had this attached to a ventilator, which you don't see here in the picture, once air would go in, because there is resistance in the lungs, and that's normal, there's always some resistance in the lungs, the air would go the path of the least resistance and it would just go back out the mouth. So we need this balloon inflated so that when air enters the lungs down here at the tip, then it can only go in one direction, and that's down into the lungs. So that's why the balloon is inflated, so that air cannot escape around the tube and out the mouth. And the amount of air pushed into the endotracheal tube is important because, again, you can't really tell by this picture, but the balloon is resting on two sides of the trachea. And if you had the balloon highly, highly, highly or strongly inflated, then you could put pressure on that tracheal tissue and cause some kind of ischemia of the tracheal cells. We don't want that. We don't want to cause a problem to the patient with helping them breathe. On the reverse side, if you underinflate the balloon, well, again, because this patient cannot swallow and manage their saliva that's constantly being formed, it can drip, drip, drip down on a good day. And if the balloon's inflated properly, it'll sit on top of the balloon. It may sit on top of the balloon. But if the balloon is deflated somewhat, then it can slither into the lungs. If you have saliva, which is somewhat acidic, and a foreign body popping into your lungs, then that can cause ventilator-associated pneumonia. Again, another problem that is now caused by the healthcare team, and so we don't want to cause any problems. We want this intubation and ventilator management to be a help for the patient and not to cause more problems. So the important points to remember is that the endotracheal tube will prevent the epiglottis from closing. The patient can't swallow. There are secretions, which also means with the balloon inflated, that air cannot come up through the lungs and cross over the vocal cords, and that's why the patient cannot speak when the cuff is inflated. And although the endotracheal balloon and cuff is inflated, oral secretions and gastric secretions, they can still leak into the lungs. So there's some other methods that we're going to have to use to protect our patients. Now that the patient's intubated, well, we need to to connect them to a ventilator. And so what mode of ventilator would you choose? And then we're going to provide and explain for each of the things. But let's first talk about the ventilator itself. So what is it? Well, it's a machine that will push in air and therefore gas, because it's oxygenation, that's moved into and also out of the lungs by a machine. So mechanical ventilation is not a cure, it's support. It is support for a patient that cannot do a respiratory support for themselves. And so therefore the goal of the mechanical ventilator is to ensure that adequate oxygenation is delivered. It is to ensure that CO2 is removed. It is to help the patient feel better, in other words, reduce the signs and symptoms of dyspnea. And then it's also to help the patient rest and recondition fatigue respiratory muscles. If you've ever talked to a patient that has COPD, it's a lot of work to breathe. And these people, if they're in an acute situation, acute distress, it's a lot of work for them to breathe, and they get tired, and that's why they stop doing as well as they could do. So it is going to help them rest. And then, of course, it's there for support in situations during surgery and those kinds of things. But it's not a cure, it's just support. So therefore, the goal, once the ventilator is initiated, should be to get them off the ventilator as soon as possible, as soon as ABGs are normalized for that patient. Now, the physician is going to prescribe or decree what the ventilator settings are to be. So in our scenario, the physician has prescribed positive pressure ventilation with assist control mode, and it's going to be volume controlled with a setting of tidal volume of 600, rate of 16, FiO2 of 100%, and PEEP of 5 centimeters. Yikes. What does all that mean? Well, let's talk about it piece by piece by piece. So the first thing we talked about was positive pressure. All modern day ventilators work under positive pressure. Well, what does that mean? Well, if you go back to your anatomy and physiology, you know that for the person or you to inhale, the first thing that happens is this diagram on the right. The diaphragm will drop down and the chest muscles and rib cage will pop out. And what that does is create more negative pressure inside the thorax. And that allows air to just simply get sucked in. Because if the air in the atmosphere is at zero and you create a negative pressure inside the chest, then that creates a vacuum. And so air just automatically gets sucked into the lungs. So that's the normal process of breathing. But we've taken all of that process away because the patient not only can't breathe or may not be able to breathe because of medications that we've given them, but because they're tired and can't breathe. So we've taken that away. And because the ventilator is just going to shove in air at its own pace and not necessarily at the convenience of the patient or when the patient is ready, then that's why it's called positive pressure. It just means that the ventilator is shoving on air, ready or not, in goes the air. And the reason why you have to know that you don't have to know all the mechanics of what I just explained. What you do need to understand is because the chest now or no longer creates its own negative pressure, what happens with negative pressure, besides the fact that air gets sucked in, is that blood gets sucked up. If you've ever wondered, well, how is it that blood in my feet goes against gravity and gets brought back to the heart? It's because of that negative pressure in the thorax helps suck up venous blood so that it's returned to the right side of the heart. And therefore, what blood goes to the right side, then that blood will go to the left and then out into the body. And therefore, if you have a less venous return, then that means there's a decrease that goes to the left side of the heart, which means there's a decrease in cardiac output, and the blood pressure may drop. Notice that I say may drop. It doesn't always drop. It depends on the patient and the status of the patient. So it can drop. So you just have to be aware of that. So that's going to be one of your questions is you, the nurse, have just seen that your patient's been put on a positive pressure ventilation. What are some concerns that you, the nurse, have? And that is you're going to assess the blood pressure. And then the next setting that we talk about, that was positive pressure ventilation that we just covered. Now the next decree or physician prescription is the mode. And the mode for this patient is assist control. So what does mode mean? Well, mode just simply means how do the patient and the ventilator interact together? In other words, if I put a certain mode, and there's probably, I don't know, 30 or 40 of them. There's like a 10-page article that I read. There's a ton of different modes. And for each mode, there's a different way in which the machine and the patient can interact together. In other words, do we want the patient to take a breath, or do we not want the patient to breathe? Do we want the patient to do certain things, or do we not want the patient to do certain things? So the mode is just simply how do we want the machine and the patient to interact together. Now, in your course, you're given complete mandatory ventilation, and I think I have a slide that describes that very briefly. You're not usually tested on it, but complete mandatory ventilation is when the patient can't breathe at all. Complete, meaning the patient's breaths are completely controlled by the machine and the patient cannot breathe. You rarely ever see that in the clinical setting. If the patient is not breathing very well or very much, most of the time assist control will be there. Well, how does assist control and the patient interact together? So in the assist control mode, a tidal volume is set and a rate is set, and that is what is delivered to the patient per minute. The patient can attempt to breathe. In other words, they can get the sense that they are breathing, but as soon as they do attempt to breathe, the ventilator senses that they are attempting to breathe, and it will automatically deliver whatever tidal volume has been set. So therefore, that is the reason why I have drawn this very prehistoric figure down here, is that every breath, whether the patient delivers the breath or whether the breath is initiated by the patient, the ventilator will either do all the work or it will complete the work of breathing. So on the screen is what you can see here. This is up here, or even here, you can see that all the mountains, or what I call them, the mountains that indicate inhalation, exhalation, inhalation, exhalation, all the inhalation, exhalation mountains look the same. There is no variation whether the patient is doing the work or whether the machine is doing the work. Now, if you notice in your clinical setting that your ventilator doesn't look anything like this, that's okay. All ventilators work the same. The screen is going to be different, just like in a car. All dashes have pretty much have the same things. They have the speed, they have the fuel gauge, they have all those things, but they look different because different models make them look different. It's the same with the ventilator. They work the same, they just may look different. That was mode. Again, we'll talk about a few different modes. I've set it up on your worksheet to where you can fill it in, the most common two that you're tested on. But again, know that there's, I don't know, 20 to 30 different modes that can be instituted for your patient. So we've covered positive pressure ventilation, we've covered mode, and in this patient we covered assist control mode because that's what the physician prescribed. And now we'll talk about volume controlled with a tidal volume of 600. Let's discuss that. So what does that mean? So there are two different ways to deliver tidal volume. It can be through pressure ventilation or it can be through volume ventilation. Both of these things, pressure ventilation and volume ventilation, are methods for delivering tidal volume. Well, what is tidal volume? So tidal volume is the amount of air that is measured in milliliters that is entering the lungs. So it is just simply the amount of air that is brought into the lungs, and then it can be by the machine delivered either by pressure or by volume. Now, if you consider, go back to my car analogy, you can consider that there's two different ways to drive your car. There's manual transmission or stick shift, and then there's automatic. So it's the same with ventilators. We can either deliver by pressure or we can deliver the tidal volume by simply volume. Let's talk first about pressure ventilation. So when air, gas, is delivered until the prescribed pressure is reached, and then the pressure is maintained for a prescribed period of inspiration. So there's no set tidal volume, so the tidal volume must be continually monitored. So let's talk about that. And I use the balloon a lot. The balloon is either representative of the lung itself, or you can consider the balloon is the alveoli. In this instance, our balloon is the lung. Now imagine you had a balloon in your hand. A party balloon is what I'm talking about. You had a party balloon in your hand, and you ask a classmate to blow the balloon up while you hold your hands on the outside of the balloon. As your classmate inflates air, what are you going to feel on the surface of this balloon? Well, you're going to feel pressure as the balloon is inflated. Yes, the balloon as well as the lungs are elastic, and as the balloon or the lungs are inflated, they will stretch. And the ventilator will sense that stretching just like you would feel the stretching if you had your hands around a party balloon that was being inflated. The physician will prescribe how much pressure the ventilator can push up to. So again, that's a physics thing because there is, if we wanted to, in our party balloon, we could measure the amount of pressure that we inflated this balloon to. Same thing with the ventilator. The ventilator can measure the amount of pressure as it inflates the lungs. There is not a set amount of volume, it is a set amount of pressure and time. So in other words, in so many seconds, the ventilator can blow until a certain pressure is reached. So that's a great thing. That is a great thing if you have a patient who you are worried about. Because if you overstretch our party balloon, just like if you overstretch the lung, you can pop it. We don't want to do that. That's creating a problem by the healthcare provider. We don't want to pop that pressure. We don't want to pop that lung. So we can blow up that lung until a certain pressure is generated, and then we'll set the rate to how many times we'll blow up our balloon. So the advantages of pressure-controlled tidal volume ventilation is that you will prevent high pressures in delivering the breaths, and therefore you won't pop the balloon, pop the lung. The disadvantages are if you have a patient that has very, very stiff lungs, that means that pressure that is set will be reached very quickly, and there may not be an adequate tidal volume that's delivered. What would you expect to see with an inadequate ventilation? Well, expect to see the value on the machine as not showing a whole lot of tidal volume going in, and also CO2 retention, and therefore a resultant in the pH dropping. So if you are not ventilating your patient very well, if you're not blowing off enough CO2, you can expect to see a rise in the CO2 and a drop in the pH. That's pressure ventilation. I know it's complex. Email me if you have questions. Now let's go to volume ventilation. How can we deliver tidal volume simply from volume ventilation? Well, it's just like pouring air into a cup. And I know you cannot see air, but pretend that you can see air and you're just pouring a set amount of volume of air into the lungs. This cup is meant to represent your lung, and we're just going to pour in air by a set volume. And when you look at our tidal volume setting, I think you can correct me, but I think it was 600. So we're going to pour in 600 mils of air for each breath into the lung. So the amount of volume is based on the patient's kilogram weight and body surface area. So again, the respiratory therapist and physician will determine how much tidal volume goes in, and then the machine will just do what it's told. It will just deliver a set tidal volume with each breath. Now, the problem with a set amount is that if it's calculated wrong, you can either hypoventilate the patient or hyperventilate the patient. So you give too much air in or too little air in. Again, what are we testing by? What tells you, the nurse, that you have enough tidal volume going in, whether it's pressure or volume ventilation? You're looking at your CO2 and your pH value. Now, it's at this point that not staff, but students will email me and go, yikes, I don't have a medical degree. How am I supposed to know whether the patient should get, what mode the patient should get, what tidal volume method should be delivered, whether it's pressure or it's a volume return? So you're right. You, the nurse, do not have to prescribe. The physician is going to prescribe these things. But just as you do with your medications, your responsibility is to understand what those settings mean for your patient. And how is the patient going to respond? In other words, if you have a patient that settings are changed and you're like, you know what? I don't think you should wean this patient or stop the machine because the patient's not awake enough to respond, or this patient's blood gas, the pH is down and the CO2 is up. Perhaps we need to increase the tidal volume. That's the kind of thing you are going to respond to the physician with, that, you know what, this setting is not really appropriate. So that's why you have to kind of know which each of the settings mean, what they might be used or what situation they might be used in, so that you can discuss it with your physician and the respiratory therapist. You are not going to make the decisions. The respiratory therapist and the physicians are going to decide. And when I say physician, I don't mean just any run-of-the-mill physician, as in a physician that's just graduated from medical school. This is an intensivist. This is a specialized physician with a lot of training. This is not easy stuff to do, to figure out. And so we need very advanced practitioners to make these responsibility in setting the ventilator settings. So fret not about that. And as your settings, or as the patient's settings, are always altered, you always have to assess. That's your job as the critical care nurse, to constantly assess for distress. Did the heart rate go up? Do they appear restless? Are they agitated? Are they throwing their leg over the side of the bed? Are they trying to get up? Are they trying to pull their tube when they were previously calm? So these are the things that you look at. And then again, as I've already said, there are multiple modes that are present. I have a 20-page article if you want one. And we just really don't talk about that many in this course, because the object is to just make you aware of some things and not make you the expert in critical care. Again, I've pointed out that complete mandatory ventilation that's addressed in our course is rarely used in the clinical setting that I've seen. Now back to the respiratory failure and the settings that we've used. We've already addressed positive pressure ventilation. We've already addressed the mode. We've already addressed about volume and the two ways in which tidal volume can be delivered. Now we're going to look at rate, FiO2, and PEEP. And when we look at rate is just very simply the breaths that are delivered by the ventilator per minute. But the ventilator is pretty smart, and it can also count the rate that the patient is taking. So if I look at this here, I can see very quickly that the ventilator rate is set at 8. So here's the rate that the ventilator is set at, and that's at 8. But when you look up here, the patient rate is 12. Now, this might not seem very obvious to you, but what I want you to realize is that the ventilator has a bar, or a piece of it where the settings are going to be dialed in, and then there's a piece on the ventilator where live things, as in patient response from breath to breath to breath. So just know that this ventilator is set at a rate of 8. So the ventilator is delivering 8 breaths, and then the patient is actually taking a total of 12 breaths, which means 12 minus 8. That means there are 4 breaths that the patient is taking on their own. Again, if the ventilator is delivering 8 and the total number of breaths are 12, that means the patient is participating and taking 4 breaths of their own for a total of 12 breaths. FiO2, that is the supplemental oxygen. It stands for fraction of inspired O2 or fraction of inspired oxygen. That just means supplemental oxygen. You breathe 21%. Patients paying for a ventilator, so they usually get more than 21%. Though in our instance here, this patient is only getting room air at 21%. We could put the setting up to 40%, we could put it up to 30, 50, up to 100% is how much supplemental oxygen could be delivered. PEEP, PEEP stands for positive end expiratory pressure. Because you, on a good day, your PEEP or your positive pressure is 5 because your glottis will close, so it will exert PEEP in your body naturally. Because that tube is shoved through the glottis, then we have to add it physiologically through the ventilator. And again, I don't know how this ventilator works. I don't know how it supplies positive end expiratory pressure, but I know it does. And 5 is the normal, that is physiologic normal. PEEP of 5 is physiologic normal. Again, PEEP is positive end expiratory pressure, so it keeps the alveoli open at the end of exhalation so that the alveoli don't collapse. We will talk a whole lot more about this later. All right, we have put the patient on the setting that we just discussed. Time has passed. The ventilator setting has been changed. We still have an assist control mode. We have a rate of 16, but the total respiratory rate is 30, and the tidal volume is set at 600 mils with an FiO2 of 100%. ABGs were drawn. Here are your ABG values here. Again, pause the recording, interpret the ABG, identify what the cause for the abnormal ABG values might be, and so what is the fix. So let's look at the ABG again so that this recording isn't forever long and you don't fall asleep on me. I did not take the time to go through arrows. This ABG is uncompensated because of the elevated pH, respiratory alkalosis. Note that the CO2 is 25, so the CO2 is less than normal. This patient is blowing off a lot of CO2 through the ventilator. Now, why is that? Well, if you notice, the patient's or the ventilator rate is set at 16, but the total rate is 30, which means this patient is getting stronger. And because they're in assist control mode and they're allowed to take a breath, they are. And therefore, they've taken 14 breaths, 14 of their own spontaneous breaths. But let's recall that on the ventilator setting of assist control, every breath, whether ventilator initiated or patient initiated, will deliver, remember my mountains being all the same, will deliver a tidal volume of 600. So in effect, this patient is getting 30 breaths at a tidal volume of 600. Now, I don't mean this in a nasty way, but think this. What does that mean? That patient is hyperventilating. And that means that patient is blowing off way too much CO2, way too much CO2. And that's what's causing a respiratory alkalosis. So what's the fix? So the fix is to slow the breathing down. So the patient will retain some CO2. We want the CO2 to be somewhere in between the 35 to 40. So if you said to yourself, here's what I should switch on my ventilator, the tidal volume, either reduce the tidal volume or reduce the respiratory rate, you would be correct, which is your first Hughes clues. If you are given a ventilator setting, if you're given a mechanical ventilator setting, and the ABG that corresponds to that setting shows that the pH is up, that the patient is alkalotic, and the CO2 is down, then the fix is to decrease the rate or tidal volume. Conversely, if the patient's CO2 was up and the pH was down, then what would you do to the rate? You would have to increase it or increase the tidal volume. That's why I say to you, use your arrows because the fix is always going to be opposite for what is occurring with the patient. Now, we've talked about what the fix could be. What the fix could be. You will never on an exam be asked to choose between tidal volume or rate because it could be either or. Most physicians will do the respiratory rate. They may do the tidal volume, but most will do the respiratory rate, but know that either answer is correct. But let's go back to what the goal is. The goal of any patient that's on a ventilator is to get their ABGs, get their acid base back into the normal for that patient, and then to get them off the ventilator. So if this patient is strong enough to initiate 14 independent or spontaneous breaths, this patient's feeling better and they're ready to begin breathing. If you keep a patient on assist control for a long length of time, they will get weaker. Why? Because again, recall that in the assist control mode, any attempt at breathing by the patient, any spontaneous breaths by the patient will result in the ventilator completing the job. So the ventilator in assist control is really doing all the work. We want that patient to do the work. We need them to do the work because if I said to you, hey, I need you to run a marathon tomorrow, but oh, by the way, you just have to sit around, well, you know, that's not going to work. Your muscles have to be used. They have to be conditioned for them to work well. So we want that patient to go to work. We want that patient to breathe. And the best fix or a better fix once the patient appears to be stronger is to change the ventilator mode. To change the ventilator mode to one that would require more work by the patient and less work by the ventilator, and that mode is SIMV. That stands for Synchronized Intermittent Mandatory Ventilation. Well, how is it that SIMV, Synchronized Intermittent Mandatory Ventilation, is better? Well, it allows the patient not only to breathe spontaneously, but at their own rate and depth. So the ventilator will deliver whatever set breath and tidal volume has been dialed in, but the patient can then do their own work of breathing in between. So let's say that we have this patient on a SIMV, a rate. We have the mode as SIMV, Synchronized Intermittent Mandatory Ventilation, and we have the patient on a rate of 8. Let's do like what we had on our previous ventilator look. Let's do a rate of 8. So that means that the machine, that the ventilator will deliver a mandatory ventilation at whatever mandatory tidal volume has been set or dialed in on the settings on the machine. So here's our mandatory ventilations. Machine delivered inhale, exhale. Machine delivered inhale, exhale. And then here's our patient. Oh, I want to breathe. So here the patient inhales, exhale, inhale, exhale, inhale, exhale. So the mountains will be uneven because the patient, you and I, any patient will inhale at a varying amount of tidal volume, and then you will exhale that tidal volume out. So whatever the ventilator setting is set at, whatever the rate and tidal volume is set at, the patient will receive those mandatory breaths from the ventilator, and then the ventilator will reset as the patient inhales on their own. So this basically is synchronized breathing. So the machine will work with the patient, but the patient can work on their own. So when we talk about the new settings, we're going to say, and this is just here's an example scenario. It could be anything, but the SIMV, the Synchronized Intermittent Mandatory Ventilation settings for our patient scenario, we're going to give that patient 10 breaths. We're going to give them a tidal volume of 600. We're going to go ahead and drop the FiO2. Now that's something that I didn't point out. We noticed that the patient was on an FiO2 of 100%, and we noticed that their oxygenation status is super good. It's super good. They have a 90% PaO2, should be between 80 and 100, and their saturation is 98%. Do we want to keep them on a whole lot of supplemental oxygen? No, we don't. We don't. Because oxygen at very high levels is toxic for the cells, for the respiratory cells, for the alveolar cells. So we also want to lower the oxygen. And in this instance, we lowered the oxygen to 40%. We do a PEEP of 5, and then we do a pressure support ventilation of 20. Let's talk first about weaning. You already know that we want to get this patient off the ventilator, and the process by which we get the patient off the ventilator is weaning. Now, how fast is weaning done? Well, it's going to vary on the patient. If you had a patient that was super, super healthy but had surgery and then came out of open heart surgery, say, on a ventilator, well, we would wean them pretty quickly because they could tolerate it. If you had a patient that came in for pneumonia and had a history of COPD and had been on a ventilator 3 or 4 days, and now we're ready to wean them, well, then you know that process is going to be slower. So we're going to wean the patient. Speed of weaning is going to greatly depend on the whole picture of the patient. What do they look like? How well do they look? Is their blood pressure stable? If they're very unstable blood pressure, well, we're not going to wean them at all, even if their respiratory status is good. The whole picture has to be one of stability and readiness for weaning. What's another thing to consider with weaning? Well, consider prescribed medication. This is where I say to you, if the patient's on a lot of medications for their blood pressure, for their heart rate, for all kinds of different things, then that patient's not ready to be weaned, even if their respiratory status is doing well. Is the patient on a sedative? Well, then you should consider that this needs to be either decreased or it needs to be completely stopped, because we want our patients to be a lot more alert. Now, this sedative reduction or decrease or stopping is a very tricky thing. Let's say the patient came in for a heroin overdose, and we have that patient completely sedated, and then now we're ready to take them off. A lot of these patients who have chemical alterations or chemical enhancements, they don't do very well when we have the sedative, and so they become very combative, not because their respiratory status is bad, but because their brains are kind of wackadoodle. And so, taking the sedation off is very difficult sometimes. Again, you are not going to have to be responsible for that on your own. You're going to get help with the healthcare provider. You're going to have to work with them to try and get that patient till you get them awake enough to breathe, but somewhat sedated so they don't fight and try and pull out that tube. As you wean the patient, as the patient is weaned, so as the respiratory therapist and the physician decide on what new ventilator settings are going to be done, you, the nurse, are there at the patient's bedside 24/7, and you have to monitor your patient closely. Well, what are you going to look at? Well, you're going to look for signs and symptoms of distress, such as the respiratory rate goes way up, the heart rate increases, and at the same time they become restless and combative when maybe they weren't. And if the O2 sat decreases. Well, what happens if this occurs, if they go into distress when you have been weaning the patient? Well, you need to stop the weaning process. The weaning process needs to be terminated. And the setting that they were on before the distress began, they would go back to that previous setting. Again, are you going to do this all on your own? No. Your job is to assess. Assess what's your patient's baseline. What is happening to your patient right now? Do they appear in distress? Now let's talk about another thing that is on the settings for the SIMV, this thing in red that is new. PSV. PSV stands for pressure support ventilation. Sometimes it's just termed pressure support. Let's talk about what the patient needs, what this support entails. If you look at this picture, you can see there's the ET tube, and then you have this long coil of tubing before it gets to the ventilator. And in SIMV, or in any setting where we want the patient to do the most work of breathing, you have increased their work. Why? Because if you think about that endotracheal tube, it's about the size of a little finger, and it's definitely smaller than the airway that they normally breathe with. And then you've also added about 6 feet of tubing. So if I asked you, is that more work of breathing than breathing through your nostrils? You would, of course, say, well, yeah, it's a whole lot more work. than if that patient didn't have the tube and tubing in endotracheal tube and ventilator tubing present. So, it's not really fair to say to your somewhat weak patient, hey, I need you to do a lot of work of breathing, but I'm going to make it harder on you with this ventilator tubing and the endotracheal tube. So as we begin the weaning process, we will give them some help. And that's what pressure support ventilation is. Pressure support ventilation is help on inspiration. As the patient inhales, again, the ventilator senses that inhalation. The ventilator will then help give a little push to the air as it goes in. So consider yourself walking. If you're walking up an incline and I'm walking behind you and I push you, what am I doing? Am I walking for you? No. You're walking on your own. I'm pushing you. I'm helping you move a little faster. And that's what PSV does. PSV helps push air in. Now, just like if we were walking, I could push you a whole lot or I could push you a little bit. And that's the same thing with PSV. I could give you a whole lot of help, such as what you would see if it was at 20, or I could give you a little bit of help, which is what you would see at 5. Again, because of you OCD students, you do not have to know the numbers. The numbers are important. The numbers are there to help you realize that I can give you a whole lot of help and support on inhalation. I can push a whole lot harder, or I can barely push. And if you can see that if the rate on SIMV were to go down to 5 and the PSV was way down at 5, well, what do you know about your patient? Well, your patient's ready to be extubated. If they can maintain their arterial blood gas, their acid base, well, on very little help from the ventilator, very little support from the ventilator on pressure support, then that patient's ready to be extubated. That's what we know. And that's how it tells us, that's how this information tells us. Deep breath. I hope this has been helpful. I hope this has made sense. If it doesn't make sense, then email me.